Thank you, everyone. Thank you for the opportunity to present a couple of case reports from my clinic in Sydney. So just a little bit about me before I begin. I'm a fellow of the Royal Australian College of General Practitioners, and I'm also a board certified ketogenic nutrition specialist through the American Nutrition Association. I'm also director of Sydney Low Carb Specialists. So the two cases I brought with me today, the first case is where low carb actually resolves gastrointestinal symptoms, fairly severe ones, in a patient who'd never been on a low carbohydrate dietary approach before. And the second case, by contrast, is actually where, and it challenges the belief that low carb can be a panacea for everything. It's where someone who was doing a low carbohydrate approach wasn't actually completely able to resolve their gastrointestinal symptoms. And what we did next to overcome that challenge. So my first case, let's dive in. It's a 41-year-old female who had had a very severe pancreatitis, and it actually resulted in a 10-day admission to ICU at the initial presentation. So it's quite severe. Pancreatitis is where you get inflammation of the entire large colon. And for her, this was actually secondary to an acquired Clostridium difficile infection. She'd received multiple courses of antibiotics as a result and spent a number of readmissions in hospital as well. So she tried to work through and muddle her way through very prominent gastrointestinal persistent symptoms thereafter of nausea, bloating, abdominal pain and cramping, and this alternating diarrhea and constipation, which was debilitating to the point where she had to map out the toilets whenever she left her home. She was referred to our clinic by a low-carb supportive gastroenterologist about a year later, and she felt that her patient would benefit from having more individualised medical and dietary support, and she believed in the power of food that may be able to fix some of these symptoms that had now become chronic. When I first saw this patient, she had complained to me about the weight gain that she'd had through this time, the immense feeling of lethargy and mental depletion, and the trouble falling asleep. She was really struggling with insomnia. Her medical history was significant for a hiatal hernia, which was pressing on her stomach. So for the hernia, she was put onto pantoprazole, which is a medication that reduces the amount of stomach acid produced. Now, her medical history really wasn't significant for much else, and she was still exercising somehow, I don't know how, even with all this fatigue, 3 times a week with a personal trainer. So what was her diet like before pancreatitis? Well, it was a highly processed food diet, including Pepsi Max cans up to 8 a day. If there's one way to resolve this addiction to Pepsi Max, get pancreatitis. Because she didn't want to touch the stuff after she came out of hospital. That was one clear thing that she was able to just not want. But what it left her with was this very bland and limited food choice. She could only really tolerate toast, pasta or rice pretty much at every meal and nothing else, and was avoiding dairy because of the absolute fear that it would worsen the diarrhea. So her initial blood results showed an insulin resistance, and we're pretty strict about fasting insulin, trying to get that under 8 at least. And the fasting blood glucose was suboptimal. It was at about 5.9. But she had profound nutrient deficiencies, particularly iron, and as well as the ones listed. But that's not unsurprising when you've had such a terrible illness that would have caused malabsorption, as well as the fact that she was eating a fairly processed diet, which is nutrient devoid. So the prescription, together with one of my dietitians, Natasha Fail, we came up with, for her specifically, a well-formulated ketogenic diet that she could start and follow sustainably. So for her, the carbohydrates were kept under 20 grams per day, and the protein intake was matched to her current lean muscle mass and amount of activity, so 90 to 100 grams per day. And we initially put no limit on healthy fats. The emphasis for her specifically was also to correct nutrient deficiencies, because this is an absolutely critical thing for her feeling, her lethargy. And the last thing we included was intermittent fasting, which worked out to be a very powerful tool for her, something she could intuitively do. Luckily, she had no desire for breakfast anyway to begin with. But what it did importantly at a cell level was allow for epithelial cell repair and regeneration and healing between the tight junctions within the gut epithelium. So in terms of follow-up results, she was able to reverse her insulin resistance very, very quickly. Her nutrient intake improved and her energy levels were through the roof. And we were able to get her off the medication, so off the pantoprazole. That hiatal hernia didn't disappear, but the reflux certainly did. And in terms of physical change, she had managed to drop 16.5 kilograms in a 6-month period and 17 centimetre waist circumference reduction. With her consent today, and she was very eager to provide this, she wants to tell everybody about the power of low carb in this situation. She's provided these photos, but she wanted me to share this statement critically with you guys. So when she came to our clinic, or when I came to this clinic, I was feeling very negative and very against all of this. How am I not going to eat carbs? I just kept throwing in the negatives until I started it. Turns out it's not restrictive. In fact, I can actually eat more and I feel good again. So the eat more for her was game changing. Remember, she had limited her diet to three types of carbohydrates. So what are the future directions for her? We've now recommended, and she's already doing it. She's had nearly a month and a half worth of this resistance exercise program that she's doing under an exercise physiologist's guidance. And now she focuses on low carb as her lifestyle. It's not a diet, although she thought it was at the beginning, and she thought it was like that for a good period of time. She wants to importantly be a role model for her teenage daughters, and she recognises how impressionable teenagers can be. And her daughters are immensely proud of the progress that she's had. So conversely, let's look at case 2, which is a 68-year-old female who had been on a self-started carnivore approach for 8 months before she presented to our clinic. She was on 2 meals a day, a very lean individual, leading a very busy lifestyle, running a clinic. So her symptoms at the time that she had struggled with and had read on the internet that carnivore could improve it were bloating, pain, nausea, lethargy and constipation. These long-standing symptoms had troubled her from her 20s, and she'd been labelled as having irritable bowel syndrome for much of her life, with all traditional treatment methods suggested by various people not working for her. And wouldn't you know it, in that 8-month time, she had a great improvement in most of those symptoms. However, there were 2 things that she wanted me to look at that were not getting better. The symptoms that she was struggling with were returning whenever she included plant foods, dairy or eggs. And she had a persistent, long-standing constipation that meant that she was now already up at taking 4 bisocodyl, which is a bowel stimulant medication, and 3 capsules of magnesium, which are actually equivalent to a very hefty dose of magnesium per day, just to keep her bowels moving. When we looked into her medical history, we saw that she had a very significant history there of respiratory tract infections. So bronchiectasis, the Pseudomonas infection, and particularly this one, the Mycobacterium avium complex, which is actually a bacteria that's related to tuberculosis. So she was very unfortunate to pick this up, and it was in the community. That meant that she was on a prolonged course of antibiotics at one point in her life, which lasted for more than 1 year. And that was not without insult to her gut. We decided we had a discussion about what could we do next, what could we do to even guide where we go with this. And I suggested perhaps we should look at gut microbiome mapping and see whether or not we could have some insights into what was going on, as I suspected there was some gut dysbiosis and very likely intestinal permeability issues. So after discussion of the limitations of these tests or these types of tests and the benefits, we did proceed. There are a couple of things to know about gut microbiome mapping, and the first is that it is just a snapshot of the microbiome, and it's based on a single stool test that's self-collected in your home. And it really what we're looking for is to look at what the microbes are that might be causing disease or disrupt the gut flora. And as well as this, we also get some information about immune and digestive markers. So it's not a routine test in diagnostic care, and it's certainly not something I order very frequently at all. And it is a challenge for clinicians to interpret this. In fact, there's not many clinical guides on how to interpret these tests. So it should be used judiciously. The microbiome's a unique fingerprint, so every single person in this room is going to have a different microbiome result on testing like this. So the reference ranges can't really be used like you would use a normal blood test result reference range. So knowing the lack of validity of the tool, I thought if we're going to do it once, then we're going to need to put in an intervention after that and then repeat it to compare it just within herself to understand if by modulating her gut microbiome we would get an improvement. So these are the initial results, and her fecal secretory IgA was quite low, and what that represents is she's very vulnerable or has a very big lack of resistance to infection at the gut lining, and had an elevated fecal beta-glucuronidase, which has been associated with constipation, which remember she was suffering quite badly with. In terms of normal gut flora, what was overgrown were Enterococcus species, Escherichia species, and Clostridium species as well. And just to also highlight on the next one, she's also got an overgrowth of what we would consider a bacterial pathogen, Yersinia. With these results, we thought that this did confirm then a provisional diagnosis of a gut dysbiosis, and we made some adjustments. So with my dietitian, Natasha, we made some adjustments to her carnivore approach to ensure that she was actually on a very nutrient-dense carnivore approach, because that's actually one of the pitfalls that some of our patients fall into. And especially in the context of this patient having osteoporosis, so quite a big focus on calcium, vitamin D and vitamin K. But I referred her at this point to a specialist gastroenterology centre in Sydney that whilst they're not low carb supportive or orientated, they have a great interest and clinical and research interest in the gut microbiome, and they use novel treatment approaches as well, like fecal microbial transplant. They recommended that she use a short course of oral vancomycin and rifaximin. How interesting is that? Treat something with antibiotics that in a counterintuitive way was caused by antibiotics. Let's look at what happened. So with this kind of a treatment, it was only 2 weeks worth of oral tablets, we had a reduction an increase in the fecal secretory IgA. So that actually meant perhaps the immune function at that epithelial lining was improving or had improved. And a normalisation, according to these reference ranges, in her fecal beta-glucuronidase. But importantly, the overgrowth that we identified before, particularly in the Clostridium species, normalised, so that came down. So the second picture down there is the follow-up result. And in the bacterial pathogens, the Yersinia was addressed, so that also normalised. But how was my patient feeling? Because these are all great on paper, but did that make any difference to her clinical symptoms? So this is the point where I saw her actually got access to these results before she walked through the door. And I thought, fingers crossed. I wonder what she's going to say. She came in beaming. Her face was glowing. And she said to me, "You will not believe this. I don't need Dulcolax anymore," which was the bowel stimulant. She was on 4. And she found that happened relatively quickly after completing the two-week course of the antibiotics. And mind you, I was seeing her about four months later. And she didn't need these hefty doses of magnesium. She was now on a much lower dose of magnesium. But most importantly, she was now opening her bowels every 3 days, complete bowel motions, feeling completely emptied, and they were normal in consistency, which she never really had for quite a significant decades of her life. So for her, this was transformative, a huge impact on her quality of life. Gastroenterologists commented fairly similarly, saying, vast improvement in the gut microbiome. It very likely represented that some of the issues that she was having were actually gut microbiome deficiencies, which were never really addressed before. And I think from a clinician's point of view, probably, and also from my patient's point of view, one of the most astounding and profound impacts for her is that she found a carnivore diet largely enjoyable, but she has children and grandchildren and family who at times she would like to actually have other low carbohydrate foods included. And this is not uncommon. A lot of our carnivore patients will comment on this sort of a situation. And she was able, with some directed support from our dietitians, she was able to reintroduce some of these low carb foods to assist importantly with that sustainability aspect of an ongoing ketogenic approach. And I thought that is going to be valuable for her health span and lifespan. So thank you so much. And if you want to learn more about our work, you can see our website and our social media channels. And this is just a couple of pictures of our evolving and growing team down in Sydney. We're all personal and professional believers in a low carbohydrate approach. Thank you.
Hi everyone, I'm Avi Charlton. Thank you for having me. Thank you for letting me have a chance to speak. My talk is about my journey. I'm going to present a very short case on a case of diabetes. So just a quick introduction about me. I have a family. I've got 2 boys. They are now 13 and 10. And I'm a GP for about 20 years, not that many. And I'm also part of the mean group of Low Carb Melbourne, which is a support group which we set up almost 2 years ago in Melbourne. And just in the last month or so, I've just started up a new clinic called Melbourne Low Carb Clinic. And that is my conflict of interest in this talk because I do want more business. So to introduce myself, I was born in Hong Kong. I went to medical school in Melbourne University and I became a GP and worked in the same clinic for about 15 years, and I'm a bulk billing GP, very, very fast medicine. And I'm married and the kids are now 10 and 13. So just to start to talk about why I get into this journey, when my babies stopped becoming babies, I wanted to lose weight, same as a lot of women. I want to lose my fat. So I joined the gym. The gym had, I went to the gym 3 times a week. After a couple of months, nothing happened. So the trainer said, you have to do exercise every day. So I did, and I took up running. And he also suggested, oh, how about you do this 8-week transformation challenge? So I did just because of it's a new challenge, and I did this challenge. He put on a spreadsheet. I had to weigh my food. So I put on the plate 120 gram of protein, 20 gram of fat, and 20 gram of carbs. And after 8 weeks of body transformation challenge, I lost 4 kilos and 4%, which is basically what I wanted to lose, and I was happy. So that's basically a low carbohydrate diet that my trainer has got me on, and I was very happy. And I looked into this a bit more. I did more learning. I did the scope learning for obesity. I went to a talk for doctors by Low Carb Down Under, organised by Rod in 2019. And I did some courses by Nutrition Network, and recently I did some learning with ACNM, which is Australasian College of Nutrition and Environmental Medicine as well. And I learned about teaching my patients how to do low carb, and that's about the last 3 years. And I have had great success on getting my patients to improve in their health. And recently, I haven't put the picture here with the Society of nutritional of medical practitioners. I'm almost going to be accredited with them. So that will give me a bit of accreditation on how to use the low carb and backed by the metabolic health practitioners. So in the last few years, I have networked with lots of low carb practitioners. I set up Low Carb Melbourne with the other means that's been fantastic. And I learned from other low carb doctors from a Facebook group. And it's been a fantastic journey of mine. On my website, I write blog articles, for example, on how to teach kids to eat healthy, and my take on cholesterol now that I've learned how to practice low carb nutrition. And I post my stuff on my social media. So some of you follow me on my journey. So in the last 3 years, I've reversed diabetes and obesity, polycystic ovarian syndrome. There's a couple of women who are struggling with fertility. Now they produce babies. Mental health. A lot of people don't know mental health is related to inflammation and poor nutrition. They've improved on their anxiety and depression, gastroesophageal reflux and gout, and irritable bowel syndrome. I've had similar experience with improving irritable bowel syndrome with low carbohydrate nutrition. These women had years and years of irritable bowel, and then they've gone low carb and bowel's much better. So a couple of months ago, I woke up one day with my husband next to me, and I said, I'm not very happy with this fast medicine, 10-minute consultation, bot billing. I've helped a lot of people with low carb. A lot of people do like it. But this in-and-out medicine, the bulk billing people, they just don't care. They just want their medical certificates. They just want blood tests or their prescription. So I had a thought about it for a few days. I talked to my close friends. I went to the boss and I told him I wanted to start my own low carb clinic. I tossed up the name. I was thinking of Eastern low carb or this low carb, but I wanted to have low carb into the name of the clinic. So I come up with this name called Melbourne Low Carb Clinic to reach out to the whole of Melbourne. And I went to my boss, he's not really my boss because I contract. I am my own boss. So the principal doctor in the clinic was quite happy because I worked for him for 15 years. He was very supportive. I told him I want this clinic, I want the room outside, and he set up the signs for me, he paid for the furniture, and I've set up this clinic. I planned it for 2 months. This clinic has been working for 2 weeks. So it's just starting. I'm planning longer consultations. The patients get to choose 45 minutes or 30 minutes. It's not bulk billed, you have to pay. And I believe you pay, you're going to spend the money and you will change your health, because otherwise, why would you come and pay for me? So I'm getting patients that some of them, they haven't seen a doctor for 2 years. They're diabetic, they've had lots of complications. They've gone low carb, they've done very well, but they haven't seen a doctor because they don't want their doctor to tell them off for doing low carb. So this doctor hasn't had medical care, and I'm here to look after them. Some of them have been yo-yo dieting, and some of them do low carb on and off, and they're not very motivated sometimes. And I'm here to motivate them. And a gym owner drove past because we're on the main road. We've got big signs, Melbourne Low Carb Clinic. The gym owner contacted me, and he's keen for me to do talks on how to help their gym members to do low carb. And hopefully I will help him with more success with his gym program. So I'm going to support them with a plan and intensive follow-up. I'm going to email them. I'm going to spam them with my social media. And end of the month, we're going to do a free low-carb information night. It's a community initiative. I've got health coaches, I've got nutritionists to come and talk to them about how to improve their mindset, which Tracy McBeath is fantastic in talking about mindset, talk about the thought and the feelings and the behaviour. We can change the thought. I mean, we can't change the thought, she said. We can change how we interpret the thought and feel different. Okay, very quick. This is a case of diabetes and alcohol addiction. This man is 57. He was diagnosed with diabetes 18 months ago. He came to see me because his health coach knows that I'm low carb. And he put on weight because he's eating non-stop, depressed and eating too much food and drinking too much alcohol. So he had a health coach who told him to eat low carb, go and see me and do intermittent fasting. He's very high functioning, he's corporate and he's makes a lot of money. So his past history includes depression, anxiety, alcohol. He calls himself moderate alcohol misuse disorder. He takes a blood pressure tablet and an anti-anxiety tablet and 2 cholesterol tablets, fenofibrate and atorvastatin. So this is the busy slide, which we'll go back afterwards. He takes, when he first saw me in April, he takes blood pressure, cholesterol, and he had a BMI of 42. He was just diagnosed as diabetes, HbA1c 6.5. His cholesterol's okay because he takes a statin and triglyceride was a bit high. So I did an insulin, it was up to 20. After that, I organised a CAC score for him. It's about in the 90s. So he saw me again and he did very well with low carb. So his HbA1c has come down to 5.9. He's reversed his diabetes. His triglyceride come down and all his markers come down and insulin's come down as well. So that's fantastic. I looked at his CAC score under 100 and I decided that if with his low carb diet, maybe his statin and his fenofibrate isn't needed. But he admits that he's still struggling with a bit of alcohol. So he actually went off to see a different low-carb GP, and the GP, fair enough, had decided that he's going to put him on rosuvastatin, a different statin, and metformin to help with his insulin resistance. His HbA1c come down a little bit more, his triglyceride is still fantastic, and his insulin's come down a little bit more, which is great. So 18 months later, I saw him, which is recent. He eats 2 meals a day. He eats fantastic. He eats bacon and eggs, mushroom. Starts at 11. He eats steak and bacon and salmon and pork. But with the alcohol, he still do good patches and bad patches, he says. And he's drinking up to 1 bottle of alcohol, vodka a night. He said vodka's probably better than other beer or wine. It's a lower carb. He realised it is a problem and he wants to change it. It is a struggle for him and it is addiction. He's stressed with work and he's travelling and but his weight has come up and he's still struggling. So I told him, let's work on it. We'll practice self-compassion. So going back to the table of his blood test results, you can see his HbA1c has got a little bit worse, 6.0. It's still pretty good with not really diabetic diagnosis. He's on metformin. And his triglyceride has gone worse a little bit. His insulin has gone worse a little bit. So it's a work in progress. I thought I'm presenting this case because low carb isn't everything. There is still lots of other things like stress, alcohol, and then he realised it is a problem. Life is a windy road. It's a work in progress, and us GPs have to continue to support these people with low carb and other things and mindset and things. So here is my contact. You're most welcome to follow me. Thank you for letting me present.
So I'm presenting a case today of Mr. B. At the time I met him, he was a 71-year-old man. And he came to see me. We had a low-carb conference in Cairns, and he attended that. And then he came to see me afterwards because he wanted to get a CAC score. His usual GP had declined him a CAC score, so I agreed because I'm a pushover, and his result was 431, which he was quite not too surprised about because he had got a fairly extensive past medical history. He'd had type 2 diabetes for some years, but prior to me meeting him, he'd actually already controlled it. He'd done the low-carb keto hard yards himself. He'd reduced his weight from 127 kilograms to 88 kilograms over those 2 years. He had a history of a previous melanoma. He'd had colonic polyps. He'd been bipolar for a long time, but he controlled that with his low-carb diet too. And he's known to have some thyroid nodules, which were just under observation and follow-up. He has a monoclonal B-cell lymphocytosis, which is a precancerous state, and had also had heavy alcohol consumption in the past, but at the time I met him, he was a non-drinker. He's meticulous in keeping his records, and he kindly gave me his own graph, which he kept himself, and he shows on this how he'd reduced his blood sugar, he'd stopped his medications, and really the diabetes is not actually a problem anymore. We can pretty well say it's reversed. So he came back to see me. I didn't see him again for a year. Came back to see me again a year later. He'd been having a lot of leg cramps, but he'd found that magnesium had improved that. And he was maintaining his low-carb diet, mainly meat and dairy, a few soups, homemade soups, a few nuts now and again. And he wanted a repeat CAC score to see how he'd been doing over the year. He also mentioned to me that he'd had erectile dysfunction, which he'd had in the past, but it got better when he went keto, but it had actually come back. And so we did his repeat bloods, and I said, when we're doing your bloods, maybe we'll do your PSA, which is, for those who don't know, prostate-specific antigen. It's not really a specific marker for prostate cancer, but it can raise a few alarm bells. His CAC score had gone up, and actually, interestingly, it had gone up more than we might predict. You can predict about a 15% per annum increase, and it was a bit more than that. So we took the decision to start him on some aspirin. I suggested he add in some vitamin K2, continue his magnesium, put a bit of regular walking exercise into his regime, and maintain his ketogenic diet. But the thing that did slightly concern me was his rising PSA. It wasn't spectacularly high, but it had definitely gone up. And we weren't worried about his diabetes because it was really well and truly in remission. Fast forward now to April 21, and when I saw him after a repeat PSA. So we decided we'd repeat his PSA in a month or two, and it was actually a little bit longer than that when he came back, and his PSA had now gone up to 7.7. There was another rise in his PSA. He did still see his usual GP, and that GP had requested an ultrasound of his kidneys, urine and bladder, which were, the kidneys and bladder were normal, but it did show an enlarged prostate. And we discussed between us the need for a urology referral, but his usual GP had already agreed to do that, so we let her get on with it. And we were also a little bit concerned about the fact that his blood test now suggested that maybe his B-cell abnormality had actually converted to a chronic lymphatic leukemia. But having said that, his full blood count was normal, so we agreed we would just watch and wait. A few months later, he came back. He'd seen his GP had referred him to a urologist, and he'd had an MRI scan. This showed a background of fairly diffuse benign prostatic hypertrophy, which is not unusual in a man of his age, but there was a suspicious area in his prostate, which they thought needed a biopsy. He went on to have a cystoscopy and had the suspicious area biopsied, and it showed what we call a Gleason 3+4, which was a 7 medium-grade prostate cancer. So the Gleason score is where they take 2 samples of the prostate. The pathologist looks under the microscope and works out how abnormal the cells look and assigns a scoring system to them. And obviously, the higher the score, the more high-grade your tumour is. So his was a medium-grade tumour. He had staging investigations with a CT scan and a bone scan, which showed no spread of his prostate to his bones or other organs. So the urologist had suggested that he should have a robotic-assisted prostatectomy. So that's where they do, the urologist sits in a different room, they have a big machine in the theatre, they put ports in, and the urologist operates a remote console, and the machine does the work and takes your prostate out. It's fantastic stuff. And before that, he needed a pelvic floor assessment because we wanted to make sure he had a good pelvic floor before they started it. So he went and saw the pelvic floor physiotherapist, and he read up on cancer therapies. Remember, this is the man who charted his own diabetes progression. He's very smart, he's very well read, and he looks at lots of stuff. And he read Thomas Seyfried's listened to some podcasts that he'd given. He looked up the Warburg effect, and he found that cancer cells ferment glucose and that they can't utilize ketones for energy. So he kind of figured that his ketogenic diet was probably doing him a favor. He then decided against surgery. The real reason for that was that he was warned of the risks, and one of the risks of prostate surgery is incontinence. And he felt that the risk of incontinence was something he didn't want to take on board. He wouldn't want to live with it, particularly if there was fetal incontinence. And he was so impressed by the stuff he'd read about Thomas Seyfried and his work that he wanted to try Thomas Seyfried's protocol. He emailed Thomas Seyfried and got emails back from him. And he came to see me because by this time he had switched to my practice. I'm now his usual GP, because he thought I would be more sympathetic to supporting this than his usual GP might be. So, of course, we said, yep, that's fine. If that's what you want to do, we'll go with it. We'll do what we can. We can't really follow Thomas Seyfried's protocol because some of the things in his protocol for inhibiting glutamine are not available in Australia. But we would do what we could. I suggested he got a ketone monitor, and he measured his glucose and his ketones and monitors his GKI, which is the ratio of one to the other. And we want to try and keep that less than 1. And we would monitor his PSA. So he was a bit unwell earlier on this year. He had watery diarrhea for some weeks, which turned out to be an Aeromonas infection, which is a somewhat unusual bacterium. But that settled with the course of antibiotics. And I was a bit concerned because he had a raised CRP. So CRP is the C-reactive protein, which is a marker of inflammation and can go up in cancer. But fortunately, it settled again after the antibiotics. So I think it was just a reaction to his bowel infection. He had a further visit to the urologist in April because he'd cancelled his surgery from December the previous year, and he thought he'd go back to the urologist. We encouraged him to go for a follow-up. It didn't go well. He felt that the urologist wasn't listening to him. The urologist thought he was crazy because he wasn't having surgery, and they were on completely different pages. So he came back to see me and said, I'm not going to see that urologist anymore. And he's continued his diligent ketogenic diet and fasting, and he feels well. So when I saw him in July, he had a bit of a setback in July. He was cleaning the drains at home with caustic soda, and it exploded out of the drain, hit him full in the face, and he got caustic soda in his eyes, which, as I'm sure James Mukey will tell you, is not very good for your eyes. So he had to have high-dose steroid eye drops, and that upset his diabetes a little bit, put his blood sugar up. But fortunately, it was transient, and it all settled down. So his latest review, this is the moment you've all been waiting for. What's happening? This is his PSA chart. Now, I don't know whether there's tumour regression, but I can tell you his PSA is dropping. He's had a follow-up scan of his thyroid. It's still TIRADS 3. The TIRADS, there's a PIRADS for prostate. There's a TIRADS. These are radiological scoring systems which score how nasty your lumps look under radiology. So 3 is indeterminate, intermediate, and you just keep following them up. It's not definitely cancer, but it's not definitely benign either. So we just follow up his thyroid. His B-cell lymphocytosis, or CLL, whatever it is absolutely stable. His diabetes has been in remission for 5 years now, and his bipolar has been in remission for longer than that. So we're very hopeful that this falling PSA might indicate that his prostate cancer is doing something in the right direction. So what next? Well, I was thinking we might do another MRI scan to assess the tumour size. We might have to find a friendly urologist to do the referral, because otherwise I'll have to pay for it, because I'm not important enough to fill out Medicare-funded MRI forms. But he's going to continue his ketogenic diet and fasting. We're going to continue to monitor his PSA, and we have discussed getting a second opinion from another urologist. We've discussed hormonal manipulation, that could be chemical or surgical, and we've discussed chemotherapy and or radiotherapy if his PSA starts to go up again. So we've still got a few more options to explore to manage the glutamine metabolism. One possibility might be to put him on some chloroquine. I need to do a little bit more research into that, so if anyone knows anything about chloroquine for managing cancer, I'd love to hear from you. So my last slide is I'd like to say, because he is here, he's in the audience today, to Mr. B, thank you for having the courage to try an unconventional treatment approach. And thank you for trusting me as your doctor to help you on this journey. And thank you most of all for allowing me to present your case today, because I'm very grateful. If we didn't have brave patients like this, we'd never advance anything.